I'm Thaïs. I'm a PhD student, and I'm just going to share some of our findings from our latest study that sought to explore the barriers and the facilitators to accessing and delivering social care and support services during the pandemic in the UK. So, what are social care and support services? So they can be defined as non-clinical services that help people with dementia and unpaid carers to live well for as long as possible in their communities. In the UK, services are delivered by different sectors, providers, and across different care settings. And services can, for example, include peer support groups, home care, respite care, daycare centres, and organised social activities. So the introduction of the COVID-19 mitigation measures completely changed how services could operate, and many turned towards the use of information communication technologies, so ICT, to continue to deliver some form of support. So the pandemic really offers a unique opportunity to understand how ICT has been used, but also now to assess the appetite of its future use within service delivery. So this current study complements our previous study that sought to compare the types of services delivered and how they were delivered prior to the pandemic and during 2 time points. And we observed a shift from in-person to remote and/or hybrid approaches to delivery, often with the use of video conferencing software, telephone calls, and emails. So in this study, we sought to further understand how the delivery of social care and support services adapted during the pandemic, to explore the experiences of delivering and accessing support, but also to understand or to gain an understanding of the challenges and the opportunities presented by the use of ICT within either the current service delivery during this current hybrid landscape, but also to assist the preparedness of service delivery for future public health crisis. So we conducted some remote semi-structured interviews with social support providers, people with dementia and unpaid carers. So we purposely recruited the providers from our previous study who expressed interest in participating in some interviews, and the people with dementia and unpaid carers were recruited by convenience sampling. The interviews happened last year between May and December, and a reflexive thematic analysis was employed to analyse the data. Important to the methodology of our study was the involvement of 2 public advisors throughout sort of the lifespan of the study. So we worked with a person living with dementia and a former unpaid carer. So 81 interviews were conducted, 13 of which were providers, 7 recipients, and 1 participant who was both a recipient and a provider. Providers mostly identified as white and worked in a paid capacity within the third sector. And the recipients, we had 5 unpaid carers and 2 people with dementia. As shown in this diagram, we generated 3 overarching themes, and I'm just going to share the main findings or the main messages conveyed within each theme. So this first theme really explored how the support adapted to meet service recipients' presenting needs. So providers often employed a combination of proactive and reactive approaches to help service recipients address their basic needs and/or uphold their social and emotional well-being. So in terms of basic needs, it was helping to deliver food deliveries, prescriptions, helping to pay rent when doing so remotely wasn't possible. Also looking out for their safety in terms of COVID-19 mitigation measures, which was actually important when there was like locally implemented, but also in terms of severe emotional distress and unpaid carers expressing suicidal thoughts. In terms of promoting social and emotional well-being, this took forms of organising regular support, organised social activities, including singing groups and interactive letters. And as illustrated in the bottom quote, I dreaded ringing, I dreaded picking. I mean, I didn't do it, but it was like, what will happen? Will this be okay or not? Because the experience was showing that something that was okay last time wasn't okay the next time. And this shows the unpredictability of the needs, and which often require decision makings, as needs were at times critical, are needing urgent social care and or medical professional attention. So this second theme sought to provide meaning to how services adapted. So we found that services adapted through an ongoing process of trial and error, which was sustained by providers' motivation, creativity, and their resilience. However, when interviewed, we found great sort of diversity in terms of the guidance received, the resources allocated, access to ICT devices and digital literacy, and those factors really varied across our sample, and we conceptualized resources quite broadly. So we included, for example, things that came up was funding, access to physical spaces, number of volunteers, external partnerships with other organizations, local authorities, local artists as well to help. And so these differences in all these factors are likely to have influenced how services adapted during the height of the pandemic, but also as the pandemic started to wane. And this is the last one, and this theme really explores or perhaps more depicts the diversity in terms of service recipients' opportunity to access ICT devices, the ability to operate the ICT devices, and also the ability to benefit from accessing services remotely. And as illustrated in the bottom quote, some people with dementia and unpaid carers faced considerable challenges in accessing devices, and sometimes they had access to devices, but they weren't really compatible with newer software. And to try and bridge this gap, some providers establish sort of device, but often tablet lending schemes. And for some, it's really good, really beneficial. For others, the difficulty of helping someone to navigate a new piece of technology remotely may have undermined the success of the scheme for some. But then on the other side, you also had people with dementia and unpaid carers who were able to access technology, able to operate the video conferencing software by themselves or with assistance. And as shown in the top quote, when we started to use electronic methods like this, visually and audibly, and face-to-face, it brought me help, it brought me out of the depression. And this person with dementia benefited from accessing peer support groups by video conferencing during the pandemic. But then we also found evidence that some people with dementia just didn't really like video conferencing software. It was confusing and or minimally engaging. So there was a really varied picture. And this sort of varied picture is also reflected in providers' views towards using ICT in future service delivery. So whereas some providers really opposed the use of ICT, others identified benefits to capitalize on when used alongside in-person services. And potential barriers included person-centered care delivery due to preferences and or convenience, bypassing geographical barriers, being able to provide support to people who are housebound or who during a short-term illness, and also be non-service recipient facing benefits, potential time effectiveness of providers, and one or two providers mentioned how the pandemic had digitalized some aspects of their own working structures, which facilitated quick decision making within the team. So a mixed picture as well. And so in conclusion, to assist the use of ICT within the current sort of hybrid service delivery landscape and the preparedness to future public health crisis, it's important to invest in the ICT infrastructure and capacity across across sectors, organisation and providers, including volunteering providers, to develop guidelines outlining best practice while remotely delivering different types of services. And importantly, in the current sort of hybrid landscape now, it's important to balance the delivery of in-person and remote services to ensure that the inequalities in access are not further increased. And that was it. Thank you.